There is nothing so powerful as an idea whose time has come. Introducing the Carlson Bridge, the only patented direct composite dental bridge. What you will see next are the steps for the immediate replacement of an extracted central incisor using the Carlson Bridge technology. Please refer to our web training manual for more detailed written instructions. Tooth number 8 has slight mobility. It is sticking out to the labial and has an open contact with number 9. Tooth number 8 will be extracted and replaced with the immediate Carlson Bridge. The old resin filling on the mesiofacial aspect of number 9 is being removed. Subsequently, the mesial, facial, incisal, and lingual surfaces of number 9 and 7 are cleaned with a fine grit diamond burr to facilitate etching with 38% phosphoric acid. The infected root canal tooth is removed gently, maintaining the integrity of the facial plate of alveolar bone. The cystic pus sacs can be seen still attached to the root surface. The alveolar socket is thoroughly cleaned of any tissue remnants. The putty impression material is mixed and placed over the extraction site, firmly molding it to the linguals of the maxillary anteriors and drawing the soft material to the labial through the edentulous area. The composite is placed from tooth number 9 over the stent to tooth number 7. The material is fully cured and inspected. The stent is bound into position with the hardened composite. Here one can begin to vary shades to ensure aesthetics. Measurements of the width of the left central incisor tooth number 9 are made, and then compared with the edentulous space to ensure proper mesial distal spacing for composite application and build-up next. A third layer of core material is applied and cured. A third layer of core material is applied and cured. A fourth layer is placed on the lingual to ensure proper thickness. Note the mid-portion of the edentulous space and the formation of the lingual aspect of the pontic number 8. In upper arch cases, gravity works to one's advantage by drawing the composite to the incisal height of the adjacent central number 9. Curing and inspection is done as before. Now that the substructure and attachment wings are secure and of sufficient bulk, a glossy finishing composite is applied to the mid-portion of the pontic number 8 and smoothed and contoured to the various surfaces of the pontic. Care is taken to maintain thickness consistent with the lateral and central abutment teeth, and envision the facial curve of the anterior sextant. Any deficiencies, for example here at the cervical of number 8, can be corrected at this time with additional application of finishing composite, adjusting for the height, width, and thickness as desired for aesthetic result. Doing this now lessens the need for shaping with rotary diamonds later. As one progresses in proficiency, one need not do measuring as seen here. The stent is removed prior to finishing by simply inserting an instrument such as a porcelain filling instrument or the like between the tooth stent interface, lifting lingually from the gingival margin of the tooth stent interface, rotating with the fingers and removing. Once the stent is removed, begin the lingual reduction of the composite at the gingival tooth interface. There will be a sharp, almost knife-like edge, generally, where the composite ended on the stent. First, remove this and begin thickness reduction for the patient's comfort and proper word articulation. After cleaning the bridge, the patient can view the completed prosthesis close up for the final time and become familiar with the bite, shape, shade, and contour. Asking the patient to speak is a means of checking thickness and acceptable length that may affect word articulation and phonation.